Okay, great. So we'll be switching gears a little bit. Thanks for that actually last discussion about fatty liver disease and concomitant diagnoses, because I think as we all are starting to see, fatty liver disease is really the most common cause of liver disease with alcoholic liver disease, which Dr. Saab will discuss after this. So I have no disclosures. So we'll start off by a case presentation. This is somebody I saw in clinic 2 months ago, and very common presentation that probably will resonate with a lot of the audience. But this patient was referred to us for fatty liver disease that was seen incidentally on imaging during the workup of abdominal pain. So this was a 56-year-old Hispanic woman who had presented to her primary care doctor complaining of some very nonspecific right upper quadrant pain. She had a liver test check as part of that workup and was found to have AST and ALT slightly elevated in the 50s and 60s. That led to an abdominal ultrasound as part of the workup, which showed steatosis, for which she was referred to us. So past medical history included type 2 diabetes for the past 5 years, dyslipidemia and anxiety, no prior surgical history, and her medication list was very much in line with her past medical history, which included metformin, atorvastatin, glipizide, a PPI, and trazodone. So interestingly, she had a pretty extensive family history. So she had a grandfather who had been diagnosed with hepatocellular carcinoma. She had 2 paternal uncles and a sister who had also been given a diagnosis of advanced fibrosis and cirrhosis. And when we asked the patient, what was the etiology of liver disease, and this is a very common answer, it's usually, I don't know, or it's alcohol, right? She herself denied any alcohol use or drug use, no supplements or herbal medication use. She was born and raised in Mexico and had moved to the United States about 5 years prior. She was married, but without any children. On physical exam, it was pretty unremarkable other than a BMI of 27, which is still considered being overweight. But her primary care doctor had already started the counseling and she had already started to lose weight prior to presenting to our clinic. But on exam, other than some central obesity, there's no evidence of chronic liver disease or any stigmata concerning for cirrhosis. On laboratory data, so AST and ALT had actually improved after the weight loss. So this goes back to Dr. Troy's point about the autoimmune and fatty liver diagnoses. The AST and ALT were in the 30s. She had a normal bilirubin and normal platelet count. Her viral workup for chronic viral causes of liver disease was unremarkable, as was her biochemical workup for autoimmune hepatitis and hemochromatosis. And as you can see here, her metabolic factors were very well controlled with a cholesterol of 99 and an A1C of less than 7%. So the abdominal ultrasound showed increased echogenicity consistent with steatosis, no masses, and no evidence of portal hypertension. The FibroScan, which was done in our clinic, showed a KPA of 9.7. So this was consistent with F2 to F3 disease. The IQR, which you should look at when you do the FibroScan, was at 14%. Ideally, it's less than 15, which tells you about how reproducible the data are. And the CAP score, which is a quantitative test for steatosis, confirmed the ultrasound finding of fatty liver. So when I think about these patients, you're going to get a lot of patients similar to this presentation in your clinic. And as we'll talk about, it's becoming even a larger problem, nationally and actually globally. And I like to think of them in 3 different buckets. And the first one is, how severe is the disease, right? So can we use blood and radiographic biomarkers to help us stratify our patients and determine if they have advanced liver disease? Do we need a biopsy to make that assessment? How should we treat the patient? And if so, how do we monitor the treatment, right? So after how long do you give them to see if they're able to lose weight, normalization of liver test, and how do we assess for progression of liver disease? So I will pose all 3 questions to the panel for discussion.
Yeah, so all All excellent questions. How severe is it? I think has to do with definitely with blood testing and fibrosis testing. So we know that patients with NASH, when transaminases are elevated, may have higher mortality from liver cirrhosis, liver fibrosis, need for liver transplantation. Their morbidity and mortality will probably be higher from liver standpoint if we're not able to get the transaminases under good control. Patients who have NAFLD only based on ultrasound or fibroscan without elevated transaminases, they fall into the bucket of more into the general population. Their morbidity and mortality they would likely be secondary to metabolic syndrome, type of diseases such as heart attacks, strokes, so on and so forth. So, the severity for NASH is determined by elevation of NASH versus NAFLD, elevation of transaminases versus not. In terms of how chronic and whether it should be treated, probably look more towards the fibrosis staging, and the gold standard is liver biopsy. But I think in my practice, at least, not everyone gets a biopsy because they are invasive procedures. The liver tests are usually mildly elevated, and it doesn't really change the treatment very much. So we resort a lot to the non-invasive testing to check fibrosis. And studies have shown that patients who have fibrosis stage 3 to 4 may have higher mortality risk, not just from liver disease, from metabolic syndrome type of issues as well. So I think many of the experts agreed to treat, to start thinking about pharmacological treatment if dietary modifications don't work at around stage 2 fibrosis or higher. But I think the jury is still out on what to treat with because we don't have many therapies. How do I monitor? Blood testing, non-invasive testing as well. I don't know if we need to do a repeat biopsy on those patients if they didn't get a biopsy in the first place. I don't know, that's where I stand.
Okay. Thank you, Bishoy. Let me tell you how I do or treat those patients in my clinic. First of all, when they come to me, I check their dietary habits. This is number one. Number two, I assess if there is any advanced disease based on their blood biomarkers like fibro test or fibro score, plus imaging, plus elastography. And as you know, combining blood work and imaging and elastography add more to the sensitivity and the specificity of how advanced that NAFLD or NASH is. Number two, regarding treatment, everyone should be treated, whether it is mild NAFLD versus NASH. And the treatment doesn't mean medical treatment. This disease is self-focused disease. Patients need to work on their lifestyle modifications. I know it is difficult, and I always tell my patients that it's easy for me to tell you lose weight, but I know how difficult it is. Regarding treatments, so far there is no FDA approved medications to treat NASH, but the horizon, there is many promising medications. Recently, there is in November publication in New England of Journal, I believe, by Aaron Sanyal about semaglutide and its ability to decrease weight by like 15% in the population studied. How to monitor? This is the answer of the last question, is by abdominal ultrasound, monitoring weight as well, and we may or may not repeat fibroscan. That's what I do in my clinic.
This disease is so hard because the cure is harder than the disease. Losing weight is harder than, most of these patients are asymptomatic, minus the obesity and things. But I think that it's so hard because lifestyle changes you have to change people's habits, and that's the hardest thing to do. But you can't just give them a pill, because that's not going to help their other metabolic risk factors, which are so important in this disease. So I think that's why this is one of the most challenging liver diseases to treat.
Yes, so I agree with all that, and I think you guys pretty much gave my presentation between the three panelists, but thank you guys for the discussion. So the first thing I'd like to mention, there you go, is that there are discussions of a change in nomenclature. So we've been calling this non-alcoholic fatty liver disease, but we're now understanding more and more about the disease and how heterogeneous it really is. So there's now a push from these experts that it really should be called metabolic associated fatty liver disease, because it's more reflective really of what's going on metabolically, and it's not just about the lack of alcohol consumption. The other thing that people have been mentioning, and Bishoy gave a really good introductory about this, is that it's a disease spectrum. Right, so patients go from having a normal liver to developing what we call simple steatosis, although most of the complications at this stage are really related to cardiovascular risk and not necessarily decompensated liver disease. I think there's a paradigm shift that's starting, in which now there are a lot of studies actually talking about hepatic steatosis as being independently about outcome of fibrosis. So I think there's still a lot of research to be done in this arena. And we still don't understand of the patients with simple steatosis, those who will progress to steatohepatitis or the more aggressive form of NASH, right? And it's really when patients develop NASH that we start to worry about advanced fibrosis, cirrhosis, and their complications of hepatocellular carcinoma or decompensated liver disease, when we start to think about liver transplantation. The other sort of caveat to this disease is that we're now understanding that about a quarter of patients who present with NASH or NAFLD-associated HCC don't have underlying cirrhosis. And this is a big clinical dilemma because this patient population is currently not being targeted for screening. So it's, predicted that NAFLD-associated HCC is pretty much going to surpass any other etiology and will be the leading indication for liver transplant when it comes to cancer. So this map demonstrates the burden of NAFLD globally, and the darker the color or the redder the color, the higher the prevalence. And as you can see here, the United States, the Middle East, Southeast Asia, and Australia have the highest prevalence, and this likely parallels or mirrors the metabolic syndrome dysfunction. They sort of go hand in hand. So as we've been alluding to and talking about, non-invasive tests are becoming extremely helpful. So because NAFLD is so common, it affects pretty much a quarter of the world population, or it's estimated to affect a quarter of the world population. When we're talking about population-based screening or developing methods to screen at-risk populations for advanced liver disease, I think it's important to come up with accessible, cheap tests are going to be available to everyone. And so over time, there's been a lot of work done on biomarker discovery in this patient population. And as you can see here, there have been many described in the literature. Some are validated in NAFLD as well as other liver diseases. And you can see that the validation and accuracy is actually quite high and ranges from the high 70s to the 90s. The problem with these non-invasive blood tests is that the indeterminate cases are actually really, really high. And so just to give you an example, one really commonly used blood test is the FIB-4 score. It's, free. There is an online calculator and it uses commonly checked blood tests. 20 to 30% of all cases will actually be indeterminate in telling us if there is advanced fibrosis or cirrhosis. So the point of this is that whatever the test you choose to screen your patient with, you should understand the limitations and that the prognostic accuracy really varies quite widely. So the other method that people have been using for risk stratification is elastography, which we've been talking about the FibroScan now throughout our discussions. And there are basically 4 different methods of using elastography. There is the vibration controlled transient elastography, VCTE, also known as the FibroScan, which we very commonly use. There are other methods, including the point shear wave elastography, which uses sound methods in quantitating the fibrosis. It's not commonly used as far as I've seen. And there are the 2D versions of these tests. So more commonly is the MR elastography, which we have at UCLA. And as you can see here, is very, very accurate. So if you look at the failure rates of each test, you can see that, again, it varies very widely depending on the test. But the most common factor associated with failure is obesity. So this is a huge problem because most of our patients are obese. This is the one patient population where this is actually very helpful, but it's limited by the subcutaneous, visceral, and intrahepatic obesity. So there have been studies trying to figure out what threshold of BMI these tests are no longer helpful. And there was a really nice study that was published recently demonstrating that it prospectively collected data that the BMI threshold should be 30, which is actually, it takes out, exactly, I see Dr. Choi's reaction, it takes out a whole bunch of people, right, in our clinics. Personally, I sort of choose 35. I don't know if the other panelists have a threshold. Dr. Yanni, you use this commonly. I don't know what you do in this scenario.
Sorry, I'm on mute. Yes, I definitely use 35 as well as the cutoff, Jihane.
Okay. Yeah, so that's a big problem, right? Because it's a big portion of the patient population. The other thing that needs to be noted about using these tests, and again, Bishoy pointed at this earlier, is that if you have acute hepatitis, it will falsely increase your fibrosis stage, right? So acute hep C, acute B, certainly acute alcohol ingestion, and anything that increases blood flow to the liver. So congestive hepatopathy or someone who hasn't been fasting prior to the FibroScan, all of those tests will give you a falsely elevated fibrosis score. And one good example of this is in the hepatitis C patient population, where we saw FIB-4 scores of, 25, 30 pre-SVR, and then you repeat the FibroScan 6 to 12 months, and you see that there's a large difference between the fibrosis stage when it's only been about a year, right? You can't really go from an F4 to an F1 in 1 year after hep C treatment. So the point of showing you this is that, again, these are really helpful tests. They're non-invasive. They're available in a lot of places, not all, but it is important to understand the limitations. So what do we do? So we use a combination of tests. So what you really want to do is rule out advanced cirrhosis or fibrosis. And for that, the blood-based non-invasive test can be very helpful at ruling out disease with very high negative predictive values. If you want to rule in cirrhosis and rule out cirrhosis, then using concurrent non-invasive blood tests with elastography can be more accurate, as Dr. El-Kabani was alluding to. However, you still get 25 to 70% of cases where you get indeterminate results. And I think this is really the patient population that should be targeted for biopsy. So to summarize some of these findings, if you have a patient with NAFLD, and this can be applied, I think, to anyone with chronic liver disease, and you want to rule out advanced fibrosis or cirrhosis, I think from a population perspective, you could probably check a non-invasive blood test. Again, the FIB-4 score being the most commonly used one. If it's low, your negative predictive value is quite high, and your risk of having cirrhosis is really low. Now, there are no data as to what to do after that. Do you continue to monitor the patient yearly? Do you stop there? I would argue that if you don't have the metabolic features under control, you should probably be screening this patient at least on a yearly basis. If the non-invasive blood test is indeterminate or high, then you really want to confirm with elastography. And the use of the elastography will also depend on the confounder, which we discussed. So if there are no confounders in this particular patient and you obtain the elastography, if it confirms low risk, then it's sort of the same algorithm as having a negative predictive value for cirrhosis. If the patient has a high risk or elastography confirms F4, then you can talk to them about chronic liver disease care. If it's indeterminate, I think considering a biopsy at this stage is reasonable. If there are a lot of confounders, then the guidance is that you should probably be obtaining a biopsy. From a clinical perspective, I think what we end up doing is if you got a fibroscan and it was indeterminate or don't really trust the results, MRE is probably the next step because it's such an accurate test. But again, understanding that it's not available in most places and insurance, may limit the access to this method. So who do we treat? So as Dr. El-Kobani and Dr. Yani were discussing, all patients with fatty liver disease should be definitely counseled on lifestyle modifications, right? Independently of stage of fibrosis. However, when do we start to become more aggressive? And certainly when pharmacotherapy will become more available, the question is going to become who do we target for pharmacological treatment? So as Bishoy pointed out very nicely, there was a study that was done that included 5 trials. This was a meta-analysis of 1,500 patients. And what they found is that when the patient has stage 2 fibrosis, really the liver-related mortality rate, as shown in this graph, starts to increase exponentially, and certainly when they're F3 and F4. They also found that the all-cause mortality was also higher in these patients, with a caveat that they did not really control for other confounders. So what are the lifestyle modifications? Reduction of caloric intake, and studies have shown that about 30% reduction helps. Weight loss is a big one, and the more weight the patient loses, the more likely they are to achieve regression of not only NASH, but fibrosis. Exercise obviously is very important. We talk about it. And I think this is especially key in the lean NAFLD patient population, because if someone by our current standards is not considered obese, it's really hard to have a conversation about weight loss management when they're not considered to be overweight. But studies have shown that if you're able to get some muscle mass on the patient, that the insulin sensitivity improves. And then alcohol consumption is very controversial. So if a patient has really no fibrosis, the data is not very clear. Some studies actually show that, drinking 1 glass of wine daily might be protective. But I would argue that anybody with any stage of fibrosis should certainly be counseled on alcohol cessation. As I mentioned, the more weight loss a patient loses, the better the outcomes. So this was a nice study that was published in 2015 looking at biopsy-proven NASH, where the patients were able to lose between 3 to 10% of their weight. And patients who were able to lose 10% or greater over a 6-month period were able to have fibrosis regression. Generally, in my practice, I'll say 7 to 10% over 6 to 12 months, because the slower they lose the weight, the more likely they are to keep it off. And bariatric surgery, which again is not available to all patients, should be considered in a subgroup of patients. So there was a nice prospectively done study that was published in France last year, where they enrolled 180 patients who were morbidly obese and all had biopsy-proven NASH. And what the authors reiterate here is that the more weight loss there is over time, the more likely the patient is to have resolution of NASH and fibrosis. And when they stratify the patients based on fibrosis stage, again, you can see that at 1 and 5 years, the majority of patients went from F2 to F3 to F0 to F1. So there is hope. So if a patient comes to you with F3 and they're concerned that this is not going to get better, you can tell them that there's clearly data showing that there is regression of NASH and fibrosis with weight loss. The problem again is that bariatric surgery is not available to all patients. And, this opens up a whole new avenue, I think, for endoscopy, right? So using endoscopic methods for weight loss management, which was really nicely presented yesterday during the interventional endoscopy session. And the idea of endohepatology is very exciting, where you can do an EUS-guided liver biopsy, check portal pressures, and actually offer weight management options for the patient. And so pharmacotherapy is, as was alluded to by Dr. Al-Kavani, not currently quite an option for our patients, but it's hard to talk about pharmacotherapy without talking about the PIVENS trial that has been now published for over a decade. And this was a randomized controlled, double-blind, placebo-controlled study where they randomized patients to vitamin E, placebo, or pioglitazone. And this was for 96 weeks with a primary outcome of improvement of NAFLD activity score, mostly ballooning and inflammation, without regression, without worsening of fibrosis. And clearly you can see that the vitamin E group had improvements, as did the pioglitazone group compared to placebo. The caveat to this is that patients who had diabetes were excluded from vitamin E treatment. So this subsequently affected the 2018 AASLD guidelines because now it's not recommended to give vitamin E to patients who have diabetes. However, there was a really nice retrospective study that was propensity score matched, recently published, where they basically took all patients with biopsy-proven NASH who had F3 and F4 disease. And this particular investigator just loves vitamin E and basically gave vitamin E to a lot of his patients. Then he went back, and this was a 10-year follow-up period, so really long-term follow-up. And you can clearly see here that the transplant-free survival is much higher in the vitamin E treated group compared to the placebo. And when they looked at hepatic decompensations, there was a decreased number of hepatic decompensations in vitamin E treated group compared to placebo. But one question that always comes up is, what about the vascular events? There's a risk of hemorrhagic stroke with vitamin E, the risk of prostate cancer. But when they looked at their data sets, again, this is a 10-year follow-up period, there is no statistical significant difference in the vascular events or the non-hepatic cancers. So I think the role of vitamin E should be sort of re-challenged, and I wouldn't be surprised if some of the guidelines change in the future as more and more data comes out.
Jihane, do you know what dose of vitamin E they used?
400 milligrams BID. So very, very excitingly, the Regenerate 3 study was published in 2019. And again, this was a randomized control study where they randomized patients to either placebo or obeticholic acid, which is an FXR agonist, at 5 or 10 milligrams. And this is an intention to treat analysis that was published at 18 months follow-up. So we don't have the end of the study period at this point. However, they did meet their primary endpoint, which was improvement in fibrosis with no worsening of NASH, or NAS resolution with no worsening fibrosis, as shown here, both in the intention to treat analysis and the per protocol population. And you can clearly see a dose-dependent response. The problem is that the FDA upped their ante. So currently, to get anything approved for NASH, the bar has been set really high. And unfortunately, some of these changes in the FDA approval came after these trials were started. So it's a lot of time and a lot of money for these studies. But to get a subpart H conditional FDA approval, this is usually on the left-hand side where clinical trials are aiming. However, now they actually want to see a regression of cirrhosis, clinical endpoints, so hepatic decompensations, HCC, MELD scores, and this will require a really, really long time, as I just showed you in the vitamin E study where it was a 10-year follow-up period. So briefly, we won't go through this in detail, but I just wanted to show what's in phase 2 and phase 3 clinical trials, just for your reference. Different pathways are being targeted in here. But again, if you look at the primary outcome, a lot of these trials were started before the FDA changes. And here they're really looking at NASH resolution without worsening of fibrosis. And as Dr. Al-Kabani pointed out, the GLP-1, I think, is going to be a really interesting one to follow based on the 2 New England studies that were recently published that showed improvement in NASH and actually weight loss even in patients who did not have diabetes. So in summary, NAFLD is estimated to affect about a quarter of the world population. Lifestyle modifications and management of metabolic syndrome remain key, and really primary prevention is where it starts. So if you have a fatty liver patient, I would talk to them about talking to their family members about weight management and metabolic risk factors management, because chances are they probably have similar risks. Non-invasive tests of fibrosis have really changed the way we manage these patients. And I think now we can start talking about population health because we have methods of assessing these risks that are non-invasive and pretty cost-effective. And finally, pharmacotherapy is on the horizon, but there are still many unanswered questions, and time will tell. Thanks for your attention.
Thank you, Jihane.
Great job, Gina.